Hello, my name is Carolyn Abbott, and this is Nursing 711 Advanced Physiology and Pathophysiology, and I am presenting case study number 43, migraine headache. NB is a 41-year-old white female who presented to her primary care provider at the clinic with a pounding and throbbing headache. She states that this is the third one she's had within the past month. Her head pain is localized in the right temple and increased to peak intensity in 1 hour. She rates her pain as a 9 out of 10, along with complaints of associated neck pain. She denies any pain in the orbit or cheek and no lacrimation or rhinorrhea. She is bothered by the bright lights in the clinic but denies any sensitivity to sound. She feels dizzy and nauseous but has not vomited. Migraines affect an estimated 40 million people in the U.S. It is characterized by the presence of recurrent severe attacks of a disabling, often unilateral, pulsating headache that can last anywhere from 4 to 72 hours. The headache may be accompanied by other neurological symptoms such as nausea, neck stiffness, photophobia, phonophobia, and allodynia. Migraines are the second most disabling chronic neurological condition. Types of migraines include with or without aura and are classified as episodic migraines lasting 0 to 14 days per month, or chronic, or my personal favorite, shoot me now, at least 15 days per month. Migraines are significantly more common in women, and they experience a higher pain intensity, headache-related disability, and more associated symptoms. Studies have also found that many medical conditions are more common in people who suffer from migraines when compared with the general population. Table 2 lists the medical and psychiatric conditions that are more common in people with migraines. The risk of major cardiovascular disease and cardiovascular disease mortality increases with age in people with migraines versus those without. Migraines with an aura are a significant risk factor of stroke in people under the age of 45, women, and women using estrogen-containing contraceptives. Migraines are also shown to be twice as prevalent in psychiatric disorders, including depression, anxiety disorders, bipolar disorder, post-traumatic stress disorder, personality disorders, and suicide attempts. Although less common than episodic migraines, chronic migraines are associated with higher disability, more comorbidity, and higher healthcare use. Migraines are more than just a severe headache. They consist of a multiphasic disorder that involves a series of sensory processes evolving over time. Migraines are believed to occur in response to the activation and sensitization of the trigeminal-vascular system, as well as the brainstem and diencephalic nuclei. The trigeminal-vascular system is composed of the trigeminal ganglia, which innervate the meninges and large cerebral arteries, and the trigemino-cervical complex neurons located in the upper cervical cord. The TCC neurons send nociceptive signals to the neurons of the brainstem, hypothalamus, and thalamus, which transmit information to the cortical regions. There are four distinct phases of a migraine attack. The premonitory phase begins with activation in the posterior and lateral regions of the hypothalamus and orexins. Orexins are neuropeptides that are synthesized exclusively in the hypothalamus and are involved in neuroendocrine, autonomic, and nociceptive functions. The thalamus is responsible for relaying and modulating sensory and motor information between cortical regions and functions as the relay center for ascending nociceptive information. Approximately 25 to 30% of people with migraines experience an aura phase that is caused by cortical spreading depression, or CSD. CSD is a brief neuronal and glial depolarization wave that sweeps across the brain cortex, followed by a wave of depression. CSD results in a rise of extracellular potassium concentrations, release of glutamate, and a decrease in cerebral blood flow. The aura may precede or occur along with the headache, and it can be visual, auditory, somatosensory, or motor. The CSD activates the trigeminal afferents, causing inflammatory changes in the meninges leading to pain. During the headache phase, the presence of pain and the level of severity of the neurological symptoms are believed to be caused by the peripheral sensitization of primary afferent neurons in the trigeminal ganglion and the central sensitization of spinal cord and brain neurons. Neurotransmitters, including calcitonin G-related peptide, pituitary adenylate cyclase activating polypeptide, glutamate, and nitric oxide, are released owing to transmission of nociceptive signals from peripheral sensory neurons to second-order neurons. The release of these neurotransmitters result in cranial vessel dilation and mast cell degranulation, which causes further activation of vascular and meningeal nociceptors, resulting in a nociceptive response to stimuli that normally would not cause pain. Postdome is the phase that occurs after a migraine attack. Patients may experience extreme tiredness and exhaustion or a sudden sense of euphoria. Some patients may complain of transient headaches with sudden head movement. This phase is thought to reflect recovery of brain function. NB is a 41-year-old white female who is slightly overweight and who appears to be in acute distress. She is a recently divorced single mother of 3 sons, ages 2 through 6. She works part-time at Walmart and is attending nursing school in the evening. She describes her headache as being localized to the right temple and rates it 9 out of 10. She is also complaining of neck pain, nausea but no vomiting, and photophobia. She states that her previous headaches usually last about 6 hours and do not respond to any over-the-counter medications. Her headaches do not appear to be associated with her menses. She denies any symptoms preceding the headaches and feels totally exhausted when they finally subside. She was diagnosed with migraines at age 9. She has no known drug allergies and denies any alcohol, tobacco, or illegal drug use. She sleeps about 5 hours per night and has poor eating habits. She drinks at least 3 to 4 caffeinated soft drinks each day. Her mother and her younger sister also suffer from migraine headaches. Her past health history is significant for major depressive disorder and Zinker diverticulum. Her medications include rabeprazole and phenolzine sulfate. Vital signs are as follows: blood pressure 135 over 90 sitting, 140 over 95 lying down, and these were taken 2 minutes apart. Her pulse is 90 and regular, respiratory rate 14 and unlabored, temperature 98.5 Fahrenheit. Her weight is 165 pounds and her height is 5 feet 6 inches. HENT, skin and neck, no bruises, lacerations, masses, or deformities on the head. Her scalp is tender. Pupils are 3 millimeters and reactive to light. Fundoscopy without lesions. Her ears, she has cerumen in the left ear canal. Positive for neck soreness, but no adenopathy, thyromegaly, or bruits. Her skin is warm, dry, and pink. Lungs are clear to auscultation, resonant to percussion. Her abdomen is soft and slightly protuberant, no tender to palpation, no organomegaly or masses, no aortic, iliac, or renal bruits. Pulses are equal and full, no edema, and she is in normal sinus rhythm. She is alert and oriented. Cranial nerves 2 through 12 are intact. Her sensory is intact to pinprick and light touch, and her DTRs are 2 plus. Her labs are as follows: sodium of 144, potassium 3.7, calcium 8.5, magnesium 0.9, phosphate 2.7, bicarb of 30, and her chloride is 110. As a Christian practitioner, the use of prayer as an alternative treatment can significantly improve the spiritual well-being of patients suffering from migraines. Studies have shown that instructing patients in prayer helps to decrease the patient's frequency of migraine and anxiety, as well as an increase in pain intolerance. The healing power of prayer. Prayer triggers mechanisms that counteract stress and promotes positive emotions. It activates the immune and hormonal systems, which is conducive to healing. We must care not just for our patients' bodies, we must also care about their spiritual needs through biblically based compassionate and appropriate care. Sometimes spiritual care simply involves being present or sharing from Scripture, or just offering words of encouragement. Sometimes just asking that simple question, "Can I pray for you?" helps you connect with your patient on a personal level and helps to lessen their pain and anxiety. Here are my 3 questions for you to think about. List 4 contributing factors for migraine in this patient. Identify the single abnormal finding in the blood chemistry panel and explain its possible association with the patient's migraine headaches, and why might prophylactic pharmacological therapy be appropriate for this patient. Thank you.